Thanks everybody for joining. I want to introduce Dr. Hartman. Dr. Hartman is a third-generation Colorado native who has been practicing urology on the west side of Denver for over 25 years. Dr. Hartman went to medical school and did her urologic surgery training at the University of Colorado. When she was board certified and became a diplomate of the American Board of Urology in 1996, she was only the 113th woman in the United States to obtain that honor. Her many accolades include being a 5280 top doc. Dr. Hartman is passionate about providing excellent urologic care for both men and women. That passion led her to be trained as a robotic surgeon over 10 years ago. She is here this evening to share some information about how robotic surgery and urology are a perfect match. Take it away, Dr. Hartman. Thanks so much.
Thank you, Lene. Welcome, everyone. I'm so glad that you've joined me this evening, and I can't tell you how happy I am to be speaking to you without a mask on. Anyway, tonight I want to talk a little bit about something I'm passionate about. It's robotic surgery. I'm going to tell you a little bit about what robotic surgery is, and then I'd like to talk about 2 or 3 very specific areas of urology where it has truly revolutionized the care of urologic disease. To tell you a little bit about myself, again, I've been in practice for a while. I do a lot of different things. I'm technically a general urologist, but I see men, I see women. I do a lot of robotic surgery, and I work primarily in Golden, Colorado, but I also have a clinic in Wheat Ridge occasionally. So we're going to talk a little bit about robotic surgery. I wanted to tell you the program or the device that I'll be talking about primarily today is the Vinci robot, which is made by Intuitive Surgical. I am a trainer in Vinci for Intuitive Surgical, so other surgeons who are being trained on robotics, I do training for them, but otherwise I have no financial relationship with Intuitive Surgical or Vinci robots, but that's what I'll be talking about primarily today. I'm going to tell you a little bit so you see what you're seeing in this slide. This is what's supposed to be the patient. This is the robotic arms that have been attached. This is the console where the surgeon sits, and then this is the view that the people who are assisting and the nurses see. So again, the Vinci robot is a system that helps enhance minimally invasive surgery. Laparoscopic surgery, which has been around for ages, it improves it, and I'm going to talk about how it improves it. I think most people know of laparoscopic surgery. Maybe a friend or a neighbor had a laparoscopic gallbladder or appendix surgery, and this is a way of doing laparoscopic surgery, but it's improved. To go through how this works, at the beginning of the surgery, I place these, they're called trocars, they're small little openings into the abdomen. We fill it with CO2 to distend it, to give us a little more room to work, and then we place our instruments in the patient. Once that happens, then I go and I sit at the surgical console. And by using my hands, I run these instruments. One of my favorite questions that people ask me about robotic surgery is, what part of the surgery do I do and what part does the robot do? And my answer is, I do all of the surgery. The robot's like a puppet. It cannot do anything without me directing it to move or to do a maneuver. What is special about robotic instruments versus laparoscopic instruments? They're very, very small. One of the main things is they're wristed. They have a lot of motion to them. So when you're dissecting in the abdomen like this, it gives you a great deal of precision and accuracy. And we run these instruments by these controls here with our fingers and our arms. So again, this instrument here, unlike laparoscopic procedures, which we call straight stick surgery because they're like straight sticks that you just open and close, these instruments are wristed. And so there's like 11 different motions that this instrument can make. And so what it does is it replicates what a surgeon's hand can do when they're operating. And it's made the ability to do some very precise surgery, particularly reconstructive surgery, very accurately. How does robotic surgery apply to urology? Well, probably when robotic surgery was first FDA approved in 2000, the urologic community took over the main use of the robot, using it for prostate cancer treatment with the radical prostatectomy. And to date, it has become the gold standard for treatment for surgical removal of the prostate for prostate cancer. We also can use it for very large prostates, for simply enlarged prostates. It's extremely beneficial for patients who have kidney cancer. And so tonight I'm going to be talking about 3 specific treatments. One is for prostate cancer, one is for kidney cancer, and then the other one is for pelvic organ prolapse. There's many, many other uses. If you have an obstruction in your kidney, bladder cancer, you can actually have your bladder removed, but with a robot. If there's an injury, again, there's many more things that we can do with the robot than are on this slide, but this is where we're going to start. Let's talk about just in general why robotic surgery has improvements for the patient. Overall, better surgical and cancer outcomes, definitely, but less blood loss, less post-operative pain. And those 2 things mean less time in the hospital. People recover quicker, they get back to their regular activities. Overall, there's decreased complications because of the accuracy and the precision of the instruments, and improved cosmetic results, which matter, I think, to most of us. This is an example of what surgery looked like when we did an open prostatectomy, and this is what it looks like with these tiny little scars when we do a robotic prostatectomy. Not only are there improvements for the patient, but there's also improvements for the surgeon. As we already talked about, the suturing and the wrist articulation of the instrument make doing precision work very easy. There's actually, within the computer itself, if you happen to have a slight tremor, it automatically stabilizes it. When I sit at the surgical consult and actually look in, it's a 3-dimensional image. It's not like looking at your TV that's 2-dimensional. And that gives, again, a lot of accuracy to surgery. Something that we love is patients love it. There's improved surgical and cancer outcomes, less complications, and probably one that's near and dear to my heart is it's very ergonomic, it's very comfortable for the surgeon, and longer surgeon longevity. After 20-some years of being in private practice and using instruments that oftentimes were too large for my smaller hands, this is what I ended up having to do, is have both of my thumbs reconstructed. So if I'd been doing robotic surgery for all those years, I probably avoided this. Let's talk about something specific now. Let's talk about prostate cancer. It is the #1 cancer that's diagnosed of men in this country, if you take out superficial skin cancer. Also important, it's the 2nd leading cause of death from cancer, right behind lung cancer. So it's a very, very important disease. Last year's statistics, almost 175,000 new diagnoses were made. But more importantly, there were 33,000 deaths from prostate cancer. There are some different flavors of prostate cancer. Some prostate cancer is sort of vanilla. It can be low grade. Oftentimes those patients are put on what we call active surveillance. They don't need any treatment immediately at all. But if you have a high volume or aggressive cancer, then one of the treatments is removal of the prostate, which we call a radical prostatectomy. Radical prostatectomy is a surgery that was devised years ago, but it had really high complication rates because it's technically very difficult. And I want to explain why that is this is a side view of the male pelvis. This is the stomach here, the bladder, and then this is the prostate that sits at the base of the bladder. And as you can see, this is actually the pubic bone. It's directly behind the pubic bone. So if you make an incision in the abdomen, you have to go behind the pubic bone to even reach the prostate. And so surgery to remove the prostate was fraught with complications. It's in a very tight spot. You've got the rectum right behind here, the urethra, which goes right through the prostate, and then not shown in this picture, very importantly, the nerves that cause erections are on the outside of the prostate. So it's a technically difficult area to reach. The evolution of prostate cancer, this is sort of a busy slide, but I'll summarize it by saying that people started doing prostatectomies years ago, but there was high complication rates, particularly with erectile dysfunction and incontinence. Dr. Patrick Walsh revolutionized the procedure in 1992 by describing a procedure that's called a nerve-sparing prostatectomy, where we're able to identify the nerves that cause erections and save them during surgery. About that same time, laparoscopic surgery came about, and people were trying to do laparoscopic prostatectomies in a minimally invasive way. The problem was it was technically very difficult. For many patients, it was a very, very long procedure, sometimes 6 or 8 hours long, and it was a difficult procedure to learn. Then again, in about year 2000, robotic prostatectomy came about, and it has steadily increased the number of robotic prostatectomies that have been done. In the year 2000, there was less than 5% of radical prostatectomies being done robotically. This year, probably somewhere between 85 and 90% of radical prostatectomies are done robotically. And some of those that are not done robotically may be because of access. They may not have a robot at a hospital that's near them. So it's become the gold standard for treating prostate cancer. And this is a view of the robotic trocars that I put into the abdomen. And this is why it's so well suited for radical prostatectomy, is these instruments can reach under the pubic bone down to the prostate very easily. The camera, we can take the camera within a few millimeters of the prostate, and more importantly, within a few millimeters of the nerves that cause erections, and we can spare those. And so it is an ideal way to do a radical prostatectomy. This is a nice, albeit a little bit longer video on YouTube if you're interested. After the prostate's removed, you're left with the urethra tube and the bladder, and you have to reconnect those. And again, this is where the instrumentation from the robot is essential. We can reconnect the urethra and the bladder in a watertight seal. We leave a catheter in here, and prior to robotic surgery, the catheter oftentimes would stay in for 2 to 3 weeks. Now it typically stays in for a few days. So great advantage. These are all proven indices of improvement using a robot to do a radical prostatectomy for prostate cancer. There's been demonstrated shorter hospital stay, faster recovery, significantly less blood loss. Prior, when we used to do open prostatectomies, it wouldn't be unusual to lose 800 or 1,000 milliliters of blood doing the surgery. Doing it robotically, typically well less than 100 milliliters of blood loss. The cancer outcomes are improved because we have such good visualization, less time with the catheter, which I already spoke about, improved ability to do nerve sparing because we have such great visualization and such great precision with the instruments. It makes this easier, and also improved bladder control. So I'm going to shift gears a little bit and talk about kidney cancer. Kidney cancer comes in 2 types. There is the kidney cancer that originates from this part of the kidney, which is like the meat of the kidney. That's the part of the kidney that filters the blood that makes urine. When tumors arise in this area, they're called renal cell carcinoma. And they can be smaller lesions like this, or they can be large tumors that are as big as a softball, or in some cases a football. With the robot, we can find, particularly for smaller tumors, the ability to remove just the tumor and leave the remaining healthy kidney behind. For larger tumors, we can use the robot to remove the entire kidney. The other type of cancer that can affect the kidneys is a cancer that affects the lining inside the kidneys. The meat of the kidney is what filters the blood and makes the urine, but a series of funnels that urine down the ureter into the bladder. And you can get cancer anywhere in this lining. You can get it in the ureter, you can get it up in the collecting system. Oftentimes, if you have a tumor up here, you need the kidney removed, but you also need the entire ureter removed. Robot is excellent for doing this procedure because you're able to do the kidney and remove this tube, as well as remove a small bit of the bladder very easily. I want to focus a little bit on one of the procedures I do quite frequently. It's called a partial nephrectomy, and it's where we're removing just part of the kidney and leaving the remainder of the kidney behind. Another one of the wonderful improvements in this surgery has been robotic surgery. Used to be, before we could have this minimally invasive approach, people had very large incisions. They had a lot of time in the hospital, a lot of recovery. It was very difficult. Nowadays, we can do it minimally invasively. This is a diagram of a robotic partial nephrectomy. You can see here, this is the tumor that we're removing. This is the aorta, which brings blood to the kidney, and then this is the renal vein, which takes blood from the inferior vena cava back to the heart. The kidneys have a very high blood flow, and so unless we clamp the artery to the kidney, if we go and try to remove a portion of the kidney, there'd be significant blood loss. This way, we're able to dissect, it's called the hilum, which is where the renal vessels are. We're able to put these small clamps on the vessels so it stops the blood flow for a short period of time. And then with the precision instruments, we're able to carefully carve out just the lesion that's seen. Using the robot, we are able to do many more small tumors than we used to be able to do in an open fashion. And because of that, we're saving a lot more of the kidney function overall, if possible. After the tumor has been removed from the kidney, then you have to fix the kidney because you end up with sort of a big hole in the kidney. And so using these instruments, we sew the kidney together and we close it. Again, the wristed and the motion of these instruments makes this procedure really quite easy compared to open surgery or even laparoscopic surgery. These are proven indices of improvement using the robot to do partial nephrectomy, shorter hospitalizations, reduced risk of infection, minimal scarring, less pain, fast return to normal activities, and less blood loss. Let's talk a little bit about the scarring. So these are scars from nephrectomies where we're not removing just part of the kidney, we're removing the entire kidney. And this is an example of an old open scar, it'd be a large flank incision like that. This is a gentleman named Cameron. He's a Canadian actor that I'm unaware of, but apparently he had robotic surgery to remove a kidney. And you can see he just has these small little openings and then one slightly larger opening, which is what we use to remove the entire kidney. And I would like to say that if you have robotic surgery, you will probably end up with six-pack abs like this gentleman does. Let's shift gears a little bit. I'm going to talk about pelvic organ prolapse. Pelvic organ prolapse, a lot of people don't know what it is, but it's where the vagina or the uterus lose their support. I've had patients come to my office terrified that they had a tumor or cancer because something was coming out of their vagina. It can result from previous hysterectomy, having children. Sometimes it runs in the family. And you can have either the uterus that's protruding or part of the vaginal wall. When people have prolapse, there's a lot of different options. Some of them are conservative. Not everyone needs surgery. We can do surgery vaginally, but you often have more scarring of the vagina. One of the ways to address pelvic organ prolapse is a procedure called a sacrocolpopexy, which basically means sacrum means tailbone, and colpal means the vagina, and it means you're pexing the vagina back to the tailbone. You're recreating the normal anatomy. And it's been the gold standard to treat pelvic organ prolapse for many years, but it used to be very difficult. I'm going to show you, this is the prolapse. Typically, there's a ligament that goes from the bottom of the uterus here. This is a side view of the female pelvis to orient you. There's a ligament that goes from the bottom of the uterus to the tailbone called the uterosacral ligament. And with previous hysterectomy or with childbirth, you lose some of that support. What a sacrocolpopexy is just recreating that normal anatomic approach, anatomic support. And so you recreate the top of the vagina to the tailbone. Years past, this was a procedure that was difficult. The sacrum is in the very back of the abdomen. Only patients who were younger and healthy could really withstand the procedure. Oftentimes patients were hospitalized for days and there was much more complications. Then came along laparoscopic surgery, which was an improvement, but there's still a lot of suturing or sewing involved with the sacrocolpopexy. And so then came along robotic surgery. And with the robot and the wristed instruments, we're able to do that sewing very easily. These are, again, proven indices of improvement using the robot to do a sacrocolpopexy. Less postoperative pain. We usually use a nerve block that helps block the nerves of the abdomen. I've had patients who didn't take anything more than Tylenol after the procedure with the robot. significantly less blood loss and blood transfusions, less infection, obviously less scarring. We have these small little openings, shorter hospital stay. People are usually in the hospital overnight. They go home the next morning. I've had a few patients go home that same day. Fast recovery times, and overall just excellent outcomes. So these are a couple of our robotic surgeons from Pod A or Golden, Colorado Urology. Dr. Zukowski, he's a gentleman who does a lot of our prostate surgery. This is me sitting at the robotic consult. And in the Golden location, we also have Dr. Brent Winship and Dr. Thomas Fassell, who are also excellent robotic surgeons. Also throughout the Colorado Urology Network, there's several other wonderful robotic surgeons that are able to use these skills to help you with your urologic issues. So in closing, like all therapies, there are risks and benefits, and only you and your physician can decide if this is the right approach and this is the right procedure that you need. Since 2000, robotic surgery has vastly improved many of the treatments for urologic disease. And I'm so happy that as urologists, we were really the first to accept and acknowledge and take on the robot as a very beneficial adjunct to our surgical therapy. As I said before, Colorado Urology has many skilled robotic surgeons. And so I'd like to say you're in good hands with us. This is me sitting at the consult with my robotic thumbs, happily operating away. Thank you very much for spending some time with us this evening. I'd be happy to answer any questions.
Thank you, Dr. Hartman. I do have a question that was sent in ahead of the meeting. Dr. Hartman, the question was, is everyone a candidate for robotic surgery? And can you explain that?
That's a good question. No, actually, not everyone is a candidate for robotic surgery because we have to gain access to whichever part of the body we're trying to operate on. If someone has had multiple previous surgeries and significant scar tissue, they may not be an ideal candidate for robotic surgery. There may be some patients because of other comorbidities or other health issues that can't withstand the pressure of having their abdomen distended with CO2 gas. So not everyone is a candidate. It's surprising how many people are candidates for it.
And what are the steps then to determine if you're a candidate for the surgery?
Well, you make an appointment with a urologic surgeon. They will typically review your x-rays or review your pathology. They'll go through your previous medical history. They'll go through what medications you're on, and then you'll have a joint discussion about what your options are and what your treatment options are and whether robotic surgery would be right for you.
Thank you. I do have another question, Dr. Hartman. This individual has a hernia in the belly button, and could it be taken care of at the same time?
It depends on what procedure you're doing, but we are doing a lot of combined surgeries with our general surgery colleagues. And I have done surgeries where we fix a hernia at the same time that we do a kidney or prostate surgery. So the answer is it depends, but sometimes yes.
The next question that I have, are there other uses for robotic surgery beyond urology?
Yes, although urology was sort of the first specialty to sort of adopt the robot, general surgeons are using it for colon resections, for appendectomies, for gallbladder surgery. Chest surgeons are using it for lung resections. There's a different robotic platform that's starting to help with orthopedic surgery. There's some ears, nose, and throat surgeons that do neck surgery with the robot. So there's lots of other uses for it. It's not just urologic. That's a good question.
This participant is wondering if you can speak a little bit about BPH.
Well, BPH, what it stands for is benign prostatic hypertrophy. And what that means in real language and not medical language is an enlargement of the prostate. Men's prostates starts relatively small in their 20s and 30s, and somewhere around age 40, a gene turns on and the prostate starts to slowly grow. And that process, the pathologic term for that is BPH. The difference from man to man is how quickly that prostate grows and whether that prostatic growth causes symptoms or obstruction. And there's many different treatments for BPH, from phytochemicals or supplements, to pharmacologic. There's minimally invasive procedures that we do in the office. There's laser surgery. And again, for a small number of patients who have very large prostates, robotic removal of the prostate in what we call a simple fashion versus a radical prostatectomy is possible.
Thank you. Another question. Can you speak to the complications of robotic surgery, Dr. Hartman?
That's a really good question, and I didn't really cover that at all in my talk. Just like any surgery, there can be complications. Anytime that you're placing trocars in the abdomen and insufflating the abdomen, there's a chance that other organs in the abdomen can be injured. The fact that the robotic instruments are so precise and the visualization is so excellent, it helps minimize that. And then just any of the complications that can happen with open surgery can happen with robotic surgery, because ultimately the surgery is the same, whether you're taking a kidney out in an open fashion or laparoscopic fashion or robotically, you're still doing all the steps to remove a kidney. And so all the potential complications associated with that can be occur robotically or otherwise.
If you could just, for a moment, I wanted to put up the website for Colorado Urology, but just to speak to it, it's www.coloradouro.com. And Dr. Hartman and her partners that she mentioned are all taking new patients. So feel free to place a call to 303-985-2550 if you have any questions or would like to set up a consultation. We do have another question. What are the percentages of permanent incontinence after surgery?
I'm assuming you're talking about robotic prostatectomy surgery, and the biggest risk with that is what we call stress incontinence, which is the type of incontinence that you get if you cough or you sneeze. And with robotic surgery, I think the permanent risk of incontinence is probably less than 3%. There's lots of treatment options. There's some men who, and that's the number of men that have like complete incontinence where they need another procedure. Probably somewhere around 15 to 20% of men may have a very, very small leakage. But some of that is surgeon dependent. And the more expertise and the more experience that you get on the robot, like with Dr. Zukowski, your personal statistics get better and better.
Dr. Hartman, any guess at how many robotic surgeries you've done in your 25 years?
Well, I've only been a robotic surgeon for 10, but it's well past 500. I sort of stopped counting. I don't know. Actually. So my answer is I don't know, but it's a few. It's more than 10 or 20, let's just say that. And, you know, if this isn't the right format or you don't feel comfortable or you don't want to discuss your questions in this manner, make an appointment. You know, with COVID-19, we're doing a lot of telehealth, so you don't even necessarily need to come to the office. We can, chat in a private, encrypted manner such as this. There's also appointments you can have in the office with, like we said, all of us are taking new patients, and we're trying the best we can to accommodate everyone's needs, whether it's with telehealth or in-office appointments during this time.
I do have another question. How long does it generally take to regain bladder control, Dr. Hartman?
You know, it varies. Some men, because the anastomosis is so good that you take the catheter out and it's literally within days that they're like not wearing pads anymore. Some men need to work on building their pelvic floor muscle strength. So some men, it may take several weeks to months, but on average, it's just several weeks doing it robotically. Some men, if their muscles are weaker, they may take them, like going to a physical therapist, and it could take up to 2 or 3 months, but that's on the long end.
A participant would like to know how long between a consultation and when the surgery could actually happen for prostate.
It depends on when the biopsy was, because we like to allow some time for the biopsy area to heal. Some of it also depends on our ability to get robotic time. In the hospitals that we work at, there are 2 robots that work, 5 and sometimes 6 days a week. but all of the robotic surgeons are vying for that robotic time. We have time for our practice that's reserved on the robots, so it depends on a lot of different factors. Sometimes it could be as quick as 2 or 4 weeks, and sometimes it might be more like a month or 2 months, depending.
And again, to get more information on that, feel free to, call the Golden office at 303-985-2550, and we can get an estimate for you. I do have another question. How long after prostate surgery, Dr. Hartman, to what you would call full recovery?
I would say you get the catheter out in 5 to 10 days. And then from that point forward, it's usually a good 2 or 3 weeks. We do restrict your lifting for a total of 6 weeks, but we have many patients who go back to their work within, a month easily. Within 6 weeks, you're about 90% healed, and that's true for most surgeries. And that last 10% of recovery takes a longer period of time. It takes oftentimes up to 6 months. And that's true whether you have a kidney surgery or prostate surgery. But by 6 weeks, the vast majority of people should be back to their regular activities.
And then how long is a partial nephrectomy procedure generally take?
It varies a little bit on body habitus, whether someone's had previous surgery, but typically it takes somewhere between 2 and 3 hours. When we take a patient to the operating room, it takes about 45 minutes to do anesthesia, do the positioning, do the nerve block, get the robot attached. So the actual robotic part of the surgery doesn't start for about 45 minutes. And then from there, again, depending on some other factors, anywhere from 2 to 3 hours. Sometimes shorter.
And can you drive yourself home after that or the next day?
We don't recommend that you drive yourself home. If you have a partial nephrectomy, we keep you in the hospital overnight. You have to be eating, you have to be walking, your pain has to be controlled, you have to be urinating. And once you've sort of hit all those parameters, we'll let you go home, whether that's the following day or the day after. Don't recommend that you drive yourself home. We recommend that you have a family member take you home and at least stay with you that first 24 hours just to assure that you're not having any issues. Mostly it's just precautionary, but I think it's good advice.
Another question, how about the rate of impotence with a prostatectomy?
That's a really good question. The rate of impotence, a lot of that has to do with the patient's age at the time that they're having surgery. It also has to do with their level of sexual function prior to surgery. The younger the patient is and the more, say, normal their sexual function is before radical prostate, the better their outcomes are for impotence afterwards. The other thing that comes into factor is what their disease process is. If they have significant disease that extends beyond the borders of the prostate, for cancer control, we may opt to remove one and sometimes both nerves. The percentages vary widely based on your specific situation. I think the worst case scenario is typically about 50%, but if you're younger and better functioning and we don't have to remove the nerves, it's much, much less than that. The other thing with erectile dysfunction is we have lots of treatments for it. We do that day in and day out, whether it's from surgery or for other causes. And the other thing is, and I try to caution my patients having prostate surgery, is your sexual function will be different after prostate surgery. And we'll talk about the details of that. But there's lots of hope for maintaining sexual function or getting it back to your pre-surgery functioning.
Great. And then, the $1,000,000 question right now, what precautions are being taken for COVID?
That's a good one. If you come to our office today, you'd see at Colorado Urology, we're taking a lot of precautions. All of the staff are wearing protective gear. Every patient who comes in gets screened for if they're having symptoms and if they're having a temperature. We have a limited number of patients in the office at any time, and sometimes we're having patients even wait in their car before they get called up to the office to minimize close contact and keep social distancing. every person, every staff that works at Colorado Urology has been tested and retested for COVID, because we're committed to having a COVID-free environment. So you're safe to come to Colorado Urology, and we're taking every precaution that we can, because your health and frankly our health is very important.
One more question here. What can you say about seeding versus surgery?
Seeding, I assume you mean the radioactive seeds that are implanted into the prostate versus surgery. Radioactive seeds are used sometimes if there's less aggressive and less volume of prostate cancer. It was more in use, I'd say 10 or 15 years ago, and it's a form of radiation. Surgery is where we actually remove the prostate. So they're very, very different treatments. It really depends on the specifics of you, what your age is, what your family history is. If everyone in your family lives to 100, that's a little different. What your health is, what your cancer diagnosis entails, what procedure would be best for you. So it depends on a lot of different factors.
And another age question specific to the rate of impotence. You mentioned, younger. And what does younger mean in terms of age?
That's changed from when I started practice 25 years ago. I would say younger patients now, we would consider anyone less probably than 60 to 65. And when we look at patients and we look at their age, it's not really chronologic age, it's sort of physiologic age. So if you're the 65-year-old or 70-year-old guy who just ran the Boston Marathon, you're a younger patient, no matter what your chronologic age is. And the reverse is true as well. We look at more of your functional age than an actual age cutoff.
We have a question. This question is specific to Parkinson's disease, and is there a best practice for minimizing delusions for someone with Parkinson's?
I don't know the exact anesthesia recommendations. Anyone who has any cognitive issues and or neurologic disorders can be affected by anesthesia. Frankly, I think we're finding even people who don't have known neurologic disorders may have some effect of anesthesia, but I'm unaware if there's specific protocols. There may be. I think your neurologist might be able to answer that, and the anesthesiologist who does the anesthesia might be able to answer that a little bit better than I would.
Dr. Hartman, do you work with a specific anesthesiologist at St. Anthony's or at Lutheran?
No, I work, both places. I work with the group that works at both places, and I have great confidence in both of them, both of those individual groups. They're all board certified anesthesiologists, and they're excellent. If there was anyone that I didn't feel comfortable with, I would take them off my list. But to be perfectly honest with you, I don't have an anesthesiologist that's off my list for either hospital, because I feel very comfortable with all of them.
And then another COVID-specific question, what is St. Anthony's protocol for COVID and surgeries?
Well, they started several, when we were sort of at the peak of the pandemic, they were only doing urgent and emergent surgeries, and then they progressed from that to doing what they called time-sensitive surgeries, ones that weren't necessarily urgent or emergent, but were time-sensitive. And they're just starting to phase into more what we consider elective surgeries. So there was a protocol to what surgeries we could do. I believe, actually I didn't know this, that you do have a COVID test 2 days before surgery. A lot of precautions are taken when you're in the operating room, and particularly during general anesthesia. Basically, the rest of the staff has to step out of the room so that you can be safely intubated. And that way, if there's any COVID virus that's floating around, the air circulates and it doesn't affect any of the staff. Obviously, everyone has all of the protective gear on as well. And they're also, checking temperatures, checking for symptoms, not just for patients, but for anyone walking in the front door or the back door.
I will give it here 10 seconds and just remind the participants, if you have any specific questions that you would like to schedule a telehealth visit with Dr. Hartman or any of her partners, feel free to go on coloradouro.com, and you'll see telehealth options. Our safety guidelines are also on there as well. And then I'll share one more time here, the number for Colorado Urology is 303-985-2550. And feel free to place a call to the clinic and get additional questions answered by our team. I want to thank Dr. Hartman for her time.
I also just wanted to thank everyone for spending a few minutes and listening to me talk about something that I'm very excited about. And please, everyone, stay safe out there.
Thank you, Dr. Hartman. Have a good night, everyone.
Thank you.